Welcome to AETCM Emergency Medicine Channel. Shall I start?
Yes.
One 76-year-old male patient who came with complaints, early history of slip and fall at bathroom in his home and on an outstretched right hand, and complaints of pain and restriction of movements at the right shoulder joint with a brief period of LOC, no history of vomiting, seizures or ENT bleed. On initial 10-second assessment, patient conscious, oriented and obeying commands. On primary survey, airway is patent, no C-spine tenderness. Breathing, air entry bilaterally equal. Saturation is 99% with respiratory rate of 20 per minute. Circulation 160/90. Pulse rate is 76 per minute. All peripheral pulses are palpable. Disability, GCS is 15/15 with bilateral pupil equal and reactive. Moving all four limbs. Exposure, febrile.
Moving all four limbs.
No, moving three limbs. And GRBS is 156 milligram per DL. And pain score is 8/10. At that time, we give PCM 1 gram IV stat. So, since the patient has a history of LOC, we do a primary survey to rule out any causes. At that time, we took ECG, which shows normal sinus rhythm, and VBG, no acid-base abnormality. Sodium is 132 with potassium 3.6.
A 76-year-old male who has come with a history of giddiness following fall or fall followed by giddiness.
History of unwitnessed fall, there is giddiness followed by fall in bathroom while passing urine.
Okay, so probably what we are dealing with when fall in elderly, we need to definitely look into the root cause analysis. That is very important thing. So whether it's a simple micturition syncope or any other drugs that the patient is taking, specifically alpha blockers. A 76-year-old, probably he'll be on an alpha blocker. Maybe a proper advice regarding his drug medications, how to use an alpha blocker may not have been told to him. And another thing is that diabetic autonomic dysfunctions. So already he's a diabetic, all the peripheral vasculature, there will be dilatation, autonomic dysfunction, all those things can attribute. So we should know what are, maybe a diuretic, a simple diuretic itself can cause postal hypotension. So we need to see what is the primary cause of his fall. Then trauma related injuries, we need to take care of that. That is separate. But here, very key thing is that you need to look at the reason why he had a fall. Why it was an unwitnessed fall, whether it was a seizure activity. We should be going behind all those things. Okay.
Since the patient has severe pain in the right shoulder, we couldn't assess the standing BP at that point.
Okay.
So, initially 76-year-old male patient, non-case of CAD, CAG, double vessel disease, CABG done in 2021 with a history of CKD on medical management, diabetes, hypertension and DLP, presented with a history of giddiness followed by fall at bathroom in his home around 8:30 am while passing urine and with brief period of LOC and followed by pain and restriction of movements of the right shoulder joint. There is no history of chest pain, palpitation, nausea, sweating or vomiting, no history of true rotatory movements, no history of weakness of limbs, facial deviation, slurring of speech or saying to any particular side, no history of fever or headache. Allergic history, not allergic to any medications. Medical history, non-case of CAD, double vessel disease, CBG done in 2012 on ecospirin and clopidogrel, and CKD, type 2 diabetes on OHA, CKD on medical management, last creat is 2.6 and hypertension, patient is on Cilacar 10 mg and Arcomin. For DLP, patient is on atorvastatin. There is also a past history of postural hypertension 2 months back. Last meal was 2 hours back, and general examination, no pallor icterex, lymphadenopathy. Local examination, patient held the arm in an abducted and external rotated position with loss of normal contour of the right shoulder joint and a palpable fullness in the axilla. While palpating, tenderness over the right shoulder joint present, limited painful range of movements over the right shoulder joint, sensations of the arm is normal, peripheral pulsations are palpable, active finger movements are present.
What was the X-ray finding?
X-ray shows right anterior dislocation of the shoulder joint.
Okay, so we have a patient who has got a right anterior dislocation. For the discussion per se, we will not go into the aspects of how to do the procedure as such, because we have already discussed shoulder dislocation. For that person, we will do regarding procedural sedation. Okay, so what are the important things? Remember, you have got a 76-year-old gentleman with little bit of comorbidities in front of you, and you are planning to do a procedural sedation. So how will you proceed now? What are the key questions that you should be answering in this case? any case for that matter.
So we have to classify the patient according to the ASA guidelines too.
Now, the first question that whether comes in your mind, whether that procedure needs a procedural sedation or not. That's the first thing. So, what do you mean by a procedural sedation?
To give analgesia, amnesia and sedation without compromise of the cardiorespiratory function.
What about the airway?
Mild
With maintaining the airway reflex, with maintaining the respiratory parameters, without affecting the hemodynamic status, and to relieve the anxiety and the pain of the patient for a diagnostic or a therapeutic purpose. So, using a pharmacological agent. That is what is procedural sedation is all about. So, you have to be very clear and specific. These all parameters should be unaffected, and without affecting these things, you should be relieving the anxiety and pain of the patient. Previously, maybe we can call it as something called like the conscious sedation. There was a terminology used before, but you have to have better terminology where you can name it as a procedural sedation. Now, procedural sedation you have decided. So, what are the key questions that you said regarding the grading? What is that grading?
According to the comorbidities of the patient, ASA grade 1 is normal healthy patient, ASA grade 2 is mild systemic disease, controlled hypertension, obesity, pregnancy can be included in grade 2, and in grade 3 with severe systemic disease but not a threat to the life with CKD on.
So what is the stage for this patient? What is the ASA grading?
Stage 3.
It's ASA grade 3, stage 3 patient for you. Okay, so we have got not a normal young gentleman. He has got a little bit elderly and already he is on some medication and comorbidities. So now, what are the things that you will next go about in this patient? What are the prior things that you have to see? Is a grade 3 patient for you?
We have to take the consent from the bystanders.
Okay, you have taken consent.
We have to check for when the last meal is taken.
Okay.
And we have to.
Suppose I am telling he has taken meal 1 hour back.
We can give. There is a risk of aspiration, but we can give injection if the patient arrives on the ED at that time itself. We while doing examination, we understood that's a shoulder dislocation. So at that time, we can give injection perinom as a gastric motility drug.
Okay, so what else you can use? You can use your point of care ultrasound and see how the stomach is. Whether you are already seeing he has taken meal 1 hour back and stomach is already distended. You need not do the procedure straight away. You can wait for another 1 hour and then you can start off with the procedure. See, timing, and I am not saying that you need a nil per hourly patient to do a procedural sedation in emergency room. But our intervention should not create a risk of aspiration for an ASA grade 3 patient here. Okay, so I am not saying that you should wait for 4 hours, then only you should do the procedure. I am not saying that per se. Maybe you can do the same thing after 3 to 4 hours, or not after 3, maybe after 1 hour, the chance of aspiration might be low. Because already he has taken just within 1 hour. The gastric emptying time usually is 1.5 to 2 hours. By the time the stomach will be emptied, maybe he is a diabetic, that is why it is taking a little bit longer time. Maybe some medications that he is already taking is delaying his gastric emptying, and he is not moving since last 1 hour since he is in the bed. So you have to anticipate these things. So my take point, what I wanted you is that I am not saying that you need an NPO for all the patients, but preferably if they are not chances of aspiration, you need to think. Even if they are taken 4 hours back and they have taken some water in between, so that is again a risk of aspiration. So you have to be very specific, and you can just put the ultrasound and see how is the stomach. The stomach is fully distended and you are going to give an agent where there is a chance of aspiration is high. You need to anticipate that. You can give any of your antiemetic or your prokinetic agent to increasing, as you said, perinom can be used to increase the gastric emptying time. Okay, so that is one thing. Next thing,
we have to check the vitals and to connect the cardiac monitors. Heart rate, saturation and BP has to be recorded before the procedure, and we have to
before the procedure
we have to check the vitals
before the procedure, during the procedure
and after
the procedure. Yeah. So you have to, we can tell in a one shot. So you have to connect to the monitor before the procedure to document the vitals, and continuous monitoring need to happen, and ideally an ETCO2 also. Ideal scenario, you can have an ETCO2 also. This holds good for all the patient. It is not level of sedation that you are going to give. This 3 monitoring holds good for all the patient that you are planning to do for. Then
We have to arrange the O2 mask, bag and mask, and nasal airway. Since the patient
Before that, it is always better to have an airway assessment done. It is always better to have an airway assessment. Even sometimes your drugs can go wrong, your dosing can change, and always ensure that your reversal agents are also available, specifically flumazenil and naloxone. If you are using a lot of opioids, make sure that all these reversal agents are available. And where to do the procedural sedation? That is the next question. Which is an ideal place in an emergency room to do a procedural sedation? That's my question. Which is an ideal place in your emergency room for doing a procedural sedation?
red area.
No, it is not the red area. It is an area isolatedly designed for doing a procedural sedation. That will be the correct thing. Because as you know, the emergency room red area, there will be a lot of resuscitation going on there. There will be a lot of chaotic things that is happening, a lot of ambiguity, everything will be a lot of issue. So that should not affect this patient monitoring. It's always better that this patient is segregated and taken separately, and you have an area identified where all these facilities are available and where a monitoring can be done. So that will be an ideal area in the emergency room. It's not the resuscitation bay. It is a separate area defined for the doing a procedure. So that you have to keep in your mind. Then what else you want to check? In this patient, I would like to have a detailed drug history. Detailed drug history. Very key thing is to have a detailed drug history, because whatever be the drugs you are using, avoiding the interactions. What is the plan of drug? I am not asking. We will come to that. Whatever be the drugs that you are using, you should be selecting in such a way that it should be avoiding the interaction. So you should have a detailed drug history. If it's a young chap, no problem. Straight away, it's very easy. But an elderly male, you have to, don't think that you are taking some time. That is okay. The orthopedician feels that why this emergency physician is taking a long time to take a decision on this. But that's fine. You can need to risk assess the patient. You have to be a very good peri-operative physician. It is not an emergency physician, it's a peri-operative physician. You have to be an anesthetist a little bit during that time. And emergency physician have to be a good airway manager, and you should be able to assess the risk factor of the patient very well when you are using these drugs. Which drugs we will select now?
We have to give analgesia first. We can give fentanyl. Fentanyl will give only analgesia. For sedation, we can select Midas. We selected Midas for this patient along with fentanyl. Fentanyl, we initially give 50 mcg stat, and we can repeat the fentanyl dose in 2 to 3 minutes. Onset of duration is 2 to 3 minutes with
Did the patient had pain relief? How did the procedure went on? I will say it was not a great experience for the patient, I feel.
After that, we repeated, totally we give 100 mcg of fentanyl.
Okay, so here the take home message what I wanted is, if you want to use, which is your agent that you are most comfortable with? That's the first question that you should arise in your mind. Which agent you know, okay. Which agent you are most comfortable with? Which you are using day in and day out regularly without any problem. So you are selecting an agent should have an analgesia and anesthetic property. Ketamine is a very good agent, but due to certain reasons you have avoided ketamine. What is the reason that you have avoided ketamine in this elderly? Maybe due to the risk of coronary artery disease, you have avoided ketamine. So ketamine have been a good choice, but you have avoided ketamine. You have gone for midazolam and fentanyl, but the doses that you are given, maybe initially it's not adequate. But I would have asked why etomidate was not given. Why etomidate was not used for this patient? Why etomidate was not given? Etomidate is a very good agent. You have to be using in day in and day out in your emergency room. So what you have to understand is that you can use agents. You think that the recommended dose is this much. So what is the advantage when you are mixing agents? The maximum toxic effect or maximum effect of that drug we will not achieve. Suppose you are getting 100 microgram or 150 microgram of fentanyl. You are giving, for example, you are giving it for pain as well as analgesia. A little bit of analgesia as well as anesthesia also fentanyl will give. But the problem is that both midazolam as well as fentanyl can cause hypotension. If the patient has already had a fall due to a postal hypotension and you are again going to an agent where the blood pressure is going to be altered, then I will not say it's a good agent. But you have etomidate in hand. So you can give a little bit of etomidate, little bit of midazolam and a little bit of fentanyl all together. In the first attempt itself, this procedure would have been a success. So that is the most ideal thing. I am not saying that this drug should be used for this patient. This is more better drug. Each patient you should justify in giving these drugs. Whichever drugs that you are comfortable to work with. I am not saying if you don't know how to use a propofol, don't use propofol. If you are not used with a propofol, you are not familiar with propofol. Suppose you say you are not familiar with etomidate, I will not say to use etomidate, but you are very familiar to use etomidate. When you are using an induction dose of 20 mg, where you can give like 6 to 8 mg or a 10 mg of etomidate, will have a very good sedative property. So you can use, because it's a safer drug, no respiratory depression, no other major problems is happening with etomidate. So we have been using day in and day out with etomidate. And then ketamine and propofol, these are the other agents. But ketamine you have heard, propofol we are not very frequently using in our emergency room. So I will say definitely etomidate would have been a best option with a combination of fentanyl. I agree with analgesic, and you can add on analgesic properly, not just you are given paracetamol. You are given initially paracetamol, then you have added with the fentanyl. No, not an issue. Then a little bit of midazolam and etomidate. All these together, the procedure would have been happened in a one shot rather than repeating another dose of fentanyl and midazolam. So that is again very, very crucial. So which drug you wanted, I will say which drug you are most familiarized with to use with. That is the drug that you need to select. And ensure that these three things, what are the three things? Airway, breathing and circulation is being maintained. And the desired anesthesia, that is analgesic, and anxiety part of the patient is relieved. You will not get a complete sedation. Like what is happening in a patient is completely knocked out. Like a ketamine you are giving, you will get dissociative anesthesia. That you might not get in this condition. But definitely the patient anxiety part will come down and pain relief will be there. So, and again another good option will be regional blocks, but ear shoulder recursion, the regional blocks are out of questions. We will not routinely use a regional block for either. But if the same thing was a Colles fracture, you would have definitely given an axillary nerve block and you would have easily reduced. So that is another option. You can use regional blocks. Now during the procedure, you have to continuously monitoring all those things. And when you will say, okay, this patient can go home. When you will say, okay, this patient can go home.
After procedure, we have to monitor the vitals for 30 minutes. Every 30 minutes we have to monitor. And if the patient
is completely alert, conscious, oriented, able to take oral feeds, that is the time he can be discharged. So approximately it will take 2 hours. If you are given any reversal agent, after 2 hours also. Suppose you are given flumazenil for reversal, you have to observe minimum for 2 hours. So the simple, he is able to maintain his airway, breathing, circulation, no supplemental oxygen. Definitely will not discharge someone with oxygen. And also very important, his pain factor also have come down. Maybe all other parameters is okay, but his pain has not come down. So then you need to reassess him, and he might not be fit enough to go to home. So you have to ensure that these things are normal and he is able to take orally. This all after the procedure might take you 3 to 4 hours. It will take you 3 to 4 hours. Don't be in a hurry to send them off. You have to, during taking your consent, you have to tell this very clearly to the family members. They should not be having this feel that after the reduction, the soon they can go to home. That part should not be. You have to tell them that there might be a reason that you might be asking them to stay back in the emergency room or maybe to get attempted. There is a chance of failure also, but sometimes the pain is not improving. You need to evaluate him further, and maybe there is some other deficit, if a neurovascular deficit that you have detected after this, you need to get him admitted. So you have to tell all those things while you are taking your consent itself. And another important thing, what is happening in your ED, you should have your own performer. So you have seen our performer, what we are doing, the documentation, what are the drugs that we need to give. So which are the drugs that we can use, what is the maximum dose, which are the drugs that we are comfortable with to work in our emergency room. We are having a lot of drugs, but remifentanil and all we are not using. So these are some drugs we are not, but dexmedetomidine we are using. So you have to select. Procedural sedation doesn't also mean that you are shifting a patient for a CT. You have a patient with alcohol withdrawal. You wanted a CT done. You are given n number of midazolam. He is not lying down. So you need to select an agent where he is knocked down to get a CT done. So you need to use. That's also is procedural sedation. So you have to select an agent appropriately and which is more comfortable. That is more important. You should not be dealing with that drug for the first time during a lifetime. That should never happen when you are doing a procedural sedation. Even you don't know about etomidate, don't use etomidate. If you know about only fentanyl and midazolam, that should be okay. But it's always very important that you have to ensure that one senior person is there available, and always discuss with him. And these grading, risk factors, airway management, airway, what all the crash cart, all those tricks, reversal agent, ensure all the checklists in an emergency room is already available, but ensure that these things are already made available prior you start off the procedure. Okay, anything that you wanted to add? What, anything, how many?
To be monitored during this Richmond scale or the
So you have to continuously monitor the patient, and sedation also need to be monitored. The problem here is that our whatever be the procedures, what we are intending, the procedure should be over within next 10 to 15 minutes. That should be our time frame. We are not planning to do a procedure for a longer duration. So again, there can be a patient where you need to use procedure sedation, maybe a patient with burns. 20% burns has come. Okay, so the plastic surgeon has come and he is asking you that he is planning to do a dressing for this patient. She needs procedural sedation. So that also needed. You have to give pain relief. Otherwise, how will they do the dressing? So you have to ensure that, okay, this much I can give you maybe a 15 to 20 minutes. If it is more than, you should be shifting him to the theatre by giving an LMA. You can have a prolonged. So that's why many of the time the burns patient, they want to do the dressing in the theatres. They will put an LMA and they will have to, it will take 1 to 1.5 hours. So they can do a proper dressing from the operation theatre. Okay. Anything that you have prepared that we have missed?
So, only about the drugs and all those.
Yeah, the drugs and doses anybody can read from the book. But I just need to give you tips and tips what you used to use.
Check for the respiratory depression. Have to check for the chest rise also. Not only the heart rate but respiratory rate. Also check for the chest rise, and also if available
capnography is very important. It's available. It's available. N stream is available. You can just put him and you see that ETCO2 is rapidly increasing. That is going for a type 2 failure. It's available, so you can use it. And make sure that every patient is different. Every patient is different. Every patient is not the same. Maybe you think that every young chap, okay, we can give with ketamine midazolam combination, I am happy. But it's not, might be not be the same. You have to ask him what are the allergies, what are the things. Propofol, where will you avoid?
Egg allergy.
Egg allergy and soybean allergy. You have to be specific. Ketamine, where will you avoid? That's all old thought.
Glaucoma.
Ketamine? If somebody is having a significant history of atrial fibrillation, you would like to avoid ketamine. Etomidate, where will you avoid? Sepsis, septic shock, even we can give adrenal insufficiency. You can give one steroid and tackle that. But when you preparing for a UK exam, you don't see etomidate everywhere. It will cause myoclonus and pain at the site of injection. But if you give with an fentanyl or midazolam, you don't see that myoclonus. So hardly how many myoclonus that you have seen. We use left and right etomidate in our ED. We haven't seen any myoclonus for that reason. Even in the last 3-4 months, maybe you are seeing myoclonus because you have not given midazolam or fentanyl. If you give midazolam or fentanyl prior to administration of etomidate, you will not see. Okay.